just so that we have as much time for our incredible panelists. So thanks so much to everyone uh, for attending this seventh panel as part of our Dissemination and Implementation Science Speaker Series. I'm going to briefly introduce myself, the broader goal of the speaker series, and then introduce our esteemed panelists. So my name is Brianna Last, and I'm an assistant professor in the clinical area of the psychology department at Stony Brook University. And the Dissemination and Implementation Science Speaker Series is part of a project that's been funded and supported by the Academy of Psychological Clinical Science. And the overall goal of this project is to strengthen dissemination and implementation science training across clinical psychological science training programs. So as has become increasingly evident, population mental health challenges continue to rise and become more pressing across the country and around the world. And there's a real need to ensure that people can easily access high quality mental health services. The question of how to meet that need is one that dissemination and implementation scientists have really tried to answer. And our field has developed unique methods, theoretical frameworks, and models that can help move the needle on population mental health. But training in dissemination and implementation science is not widely available in clinical psychology doctoral programs. And so we've decided to make this speaker series free and virtual, hoping that we can support everyone who's interested in learning about dissemination and implementation science. So today's panel is on treatment fidelity and adaptation, and it features esteemed panelists, Doctors Bryce McLeod, Michael Southam-Gerow, and Shannon Wiltsey Stirman. Each speaker has extensive experience and expertise on this topic, and I'm just so delighted to hear about their important contributions. So I'm going to briefly introduce the panelists and then have them take it away. So Dr. Bryce McLeod is a professor of psychology at Virginia Commonwealth University. His research interests include distilling core elements of evidence-informed programs to facilitate the implementation and sustainment of evidence-informed practices in community settings, youth diagnostic and behavioral assessment, treatment integrity research, and providing training and supervision. Dr. Michael Southam-Gerow is professor of psychology at Virginia Commonwealth University and the director of the Center for Evidence-Based Practice Partnerships in Virginia. His research focuses on the partnership-driven implementation of behavioral health treatments in community-based, publicly funded settings. Dr. Southam-Gerow also studies emotion processes in children and adolescents and treatment integrity. Dr. Shannon Wiltsey Stirman is a professor in the Department of Psychiatry and Behavioral Sciences at Stanford and a psychologist at the National Center for PTSD's Dissemination and Training Division. Her research interests include implementation science, particularly training, fidelity, adaptation, and sustainment, evidence-based treatments for PTSD, depression, and suicide prevention, as well as the use of technology to support access to evidence-based mental health interventions. So each panelist is going to speak for about 15 to 20 minutes, and then we'll have a question and answer period. I'll just begin the question and answer period with some of my own questions before opening it up to the audience. And so we just request that you hold your questions until that period at the end. And if you should experience any technical difficulties or have any questions during the panel, Madeline Papard, who is waving her hand, will be able to assist you. She's also going to be monitoring the dissemination.implementation@gmail.com email in case you get kind of hopped off the Zoom for whatever reason. So without further ado, I'm just going to let Bryce take it away.
Well, thank you very much. I will start sharing my slides. Let's see here. And hoping everyone can see this. I am starting out and going to focus on definitions, kind of approach to measurement, and how one might use treatment integrity measures across different kind of settings and to ask different research and practice questions one might have. Here's my agenda for my talk. Just a little context before I launch into this talk. I think it's sometimes useful to hear the settings and contexts that folks do their work in. I'm a clinical psychologist by training. When I first started looking at treatment integrity and treatment fidelity, Mike and I actually collaborated a lot on developing treatment integrity measures to assess adherence, competence, and differentiation for CBT for youth anxiety. A lot of that work was done in university-based settings and community mental health settings, so efficacy and effectiveness trials. As my career progressed, the settings that I worked in started to include early childhood settings and elementary settings, and how to kind of assess treatment integrity and fidelity within those settings. And we've used anything from observer-based measures to self-report measures across both mental health settings and school settings. And so those are the settings that I work in. So some of the definitions and my perspectives are kind of very much impacted by kind of the demands and foci of those different settings and what you can and cannot do there. So with that background, I'm going to start by offering some definitions. I'm not saying that the definitions are correct. I would rather see them as a starting point. I'm interested to hear if the other panel members agree or disagree. And I think an issue within the field is that there's not necessarily consensus around some of the terms. I'm going to offer some of the definitions we have used, but they're just a starting point. I'm going to cover two models that have been influential in the work that we've done. One that Mike and I helped put together over 10 years ago, and another one that has helped me think a lot about treatment integrity and implementation and sustainment work. And then I'll go through kind of some things to consider when designing a measure, what the purpose of it is, how to design it, etc. And hopefully that will set the stage for what Mike and Shannon are going to talk about. All right, so treatment integrity versus treatment fidelity. You'll see both of these concepts or terms thrown around quite a bit in the field, and some of it varies by discipline, a little bit maybe in the medical field, mental health, maybe alcohol, drug. Some of it varies by content area. What I offer today is the way at least I think of treatment integrity and treatment fidelity is treatment integrity in many times is a little bit broader. It can capture adherence, so the degree to which a practitioner follows a treatment protocol, so the elements that are prescribed in the treatment protocol, competence, how well someone delivers those components, a concept called differentiation. This is relevant when you are comparing two active treatments, and it asks the extent to which the two treatments differ along lines that are to be expected. So for example, if you are evaluating CBT versus usual care in a community context, you would want to be able to ask the question, to what extent was CBT present within the usual care condition? Because in many times, CBT is in usual care today, and to varying degrees and to varying levels of quality. And knowing that helps you interpret study findings, because if CBT is in both and there's no effect for both, then maybe it's because CBT was in both. So treatment differentiation asks, do they differ along expected lines? And then other components that find their ways into some treatment integrity models are things like the quality of the alliance, how responsive a client is, the degree to which a client comprehends the lessons taught within a session. Those components aren't as consistent and as consistently mentioned across the different definitions of treatment integrity, but they are present in some of the models that are offered within the field. I think of treatment fidelity as a little bit more narrow, whereas treatment integrity sometimes includes measuring processes that may not be part of a treatment protocol. I think a little bit more of treatment fidelity as being narrowly focused on the delivery of a particular program and the degree to which it was delivered and how well. So again, I'll be interested to hear Mike and Shannon's thoughts on those, if they kind of agree or disagree with that. But that's a starting point, because I know that some of the question coming into this are, what are those terms and how are they referred to? Kind of building on that in terms of definitions, and what I've tried to do in my talk is, you'll see at the bottom there are some articles referenced that if folks want to dig a little bit further into this or get a little bit more deeper into the rationale for some of this, it hopefully will provide some resources for you to do so. This issue of adherence versus quantity, competence versus quality. As myself and Mike and I and our work kind of started edging more into kind of effectiveness and implementation and sustainment, we started raising this question about, to what extent is adherence an appropriate term to use when there's not an identifiable treatment manual or program being delivered. Some of you all may be kind of aware of modular approaches, or may be aware of efforts to kind of characterize usual care as the initial part of trying to do some sort of quality improvement process. You want to kind of ask what's being delivered, so you can then go on to the next step of figuring out what may need to be retained versus changed in order to help engage in a quality improvement process. So you'll see this kind of idea of adherence being used in the treatment integrity field when you're dealing with a treatment manual that is well specified, because you're talking about adherence to the treatment manual. And sometimes the term quantity will be used when you're trying to figure out what practices are being delivered in a particular setting, and to what extent do they map onto evidence-informed or evidence-based recommendations. I hope that makes sense to folks. Same thing about competence versus quality. Competence often is used when talking about the delivery of a particular treatment program. And quality is being talked about when judging the practices being delivered and whether they meet certain quality standards. And so this is an issue that often comes up in kind of more implementation research, where you're trying to engage in an iterative process of quality improvement, and you want practice to move towards evidence-based recommendations, but there may be not a particular manual, or there may be multiple manuals being delivered, and you're trying to judge overall to what extent does practice conform with what we know about evidence-based recommendations. So those are some of the terms that have been emerging a little bit, and we go into detail a little bit more about that in a paper that we published a couple of years ago, where we try to distinguish between adherence versus quality and competence versus quality. There are some measures that do blend adherence and competence into single ratings. I think those are very interesting. And what their rationale for doing that is that they, at least my understanding of it from reading it, is that what they're trying to do there is to make a single rating that is useful in guiding consultation and supervision. And so by kind of blending the concepts of adherence and competence, as opposed to producing separate scores for adherence and competence, kind of the rationale is argued that that provides kind of more precise recommendations for helping to coach or supervise someone. All right. So one model that Mike and I proposed, and colleagues proposed a little over 10 years ago, is this kind of quality of care model, where, and this is where the concepts of quantity and quality come in. If you're looking at a system of care and you have the structural characteristics or the inputs into the system, so the organizational level inputs, policy, etc. You have the care provided, which are the elements of treatment implementation, and you have the outcomes. You can think of the dimensions of treatment integrity as indicators of quality indicators. So if you can establish what processes you would expect in terms of elements being delivered, whether those are kind of elements of CBT for anxiety or CBT for depression, if you monitor what's being done within a system and identify the quality indicators, you can look to see how structural inputs impact processes or what's being done in the clinical room and how those processes impact outcomes. And I know Shannon and I think Mike will touch a little bit more on the relationship between fidelity and outcome. But this is one way of conceptualizing that within a system. Another model, and I'm going to lightly touch on this, but if you all aren't familiar with the dynamic sustainability framework, I would highly encourage you all to think about it. If you look at the article itself, the figure is much more appealing than this one. This is one that our group has thrown together, and it's, while colorful, it's not quite up to the standard that's in the article. I think a key thing about dynamic sustainability framework, and that really helped impact my own work, that and combined with the work that Shannon's done over the years, is in thinking about treatment integrity, as we develop an intervention, as we test its effectiveness, and then we ideally move towards sustainment and scalability, do we expect fidelity to stay the same? Or do we expect that the components of the program will need to be adapted to fit new context, whether that's the characteristics of the staff, the characteristics of the participants? Going back a couple of decades, I think many times the efforts was quality assurance. We wanted to make sure that a program was delivered consistently as it was originally designed. And there's good evidence to suggest that that may not be the case, that modifications and adaptations and so forth can actually improve fit and thus outcomes, but that's an empirical question. And it is something that I've thought a lot about. How do you adapt? What do you adapt? What should you not adapt? And this model, again, about 12 years old now, helped me kind of move away from kind of a thinking about quality assurance to more quality improvement. How can we use treatment fidelity integrity measurement to figure out if adaptations or modifications are useful and enhance effectiveness or not? All right, so treatment integrity measurement. I've got about 7 more minutes, so I will go through these and make these points. There is no one-size-fits-all integrity measure. I think one of the most important things to kind of think about is that the purpose of the measure has to align with the design of the measure. What works well in the treatment development phase is likely not going to work very well in the effectiveness or implementation phase. And so the type and focus of measurement must change over the stage in which treatment development and evaluation is in. And critically, the psychometric properties of a measure have to support the purpose of it. So, you have to have good validity evidence support the application of a measure. Possible applications of treatment integrity is the manipulation of an independent variable. Did we deliver the intervention as intended? Did we train them up to standards? Are we trying to see the outcomes of training and coaching? So more of an implementation outcome. Are we using this as a quality improvement process? Are we trying to kind of monitor processes in a large system over time? Are we trying to support implementation or promote sustainment? Each of these purposes are supported by different psychometric properties and likely different designs of the treatment integrity measure. Design considerations, who's going to be the end user? Observers are great, but they're really, really expensive. Self-report is really useful. Self-report doesn't always match up to observer report. Not saying that observer report is right, but they don't match. Item design, how much or how little are you going to capture with the measure? Scoring system, how will you generate scores on it? Most often you want to tell the difference between dosage or quality, so that suggests that you're going to do some sort of Likert type scale so that you can tell differences between groups or individuals or clients or so forth. And then finally, kind of efficiency and cost considerations. In the beginning, when you're developing your intervention, oftentimes people are using more costly, time-intensive treatment fidelity methods. But again, as you go further down the pipeline and get closer to sustainment and scaling, you better have pretty low cost, easy to use instruments. The users, researchers, experts, graduate students, undergrads, the experience level dictates how complex the system can be. Are you going to have supervisors, coaches use it? Practice-wise, and some of the work around kind of doing modular interventions often have supervisor consultants doing a lot of the fidelity ratings. And they are a really great way of doing it. It's kind of an in-between way of having an observer do it versus a practitioner. Many systems use practitioners. And if so, it better be nice and short so that they have time to fill it out. And I think this is my last slide. So reliability and validity dimensions. If you can't tell, I like measure development, so I think a lot about reliability and validity. But as you'll see here, if you're going to use a measure to evaluate whether you manipulated the independent variable appropriately versus using it for training and coaching purposes versus quality improvement or implementation sustainment, you're going to have different validity evidence to support those varied uses. And we still have a little ways to go in terms of building evidence in support of many of the fidelity measures that we use. We're still trying to figure out if they're sensitive to change over time. A lot of the time, we're still trying to figure out kind of how to make them as efficient and cost effective as possible. But I will look forward to your questions at the end. And I will stop on that note so I can hand it off to Mike.
So I just dive right in. Is that the truth? Okay, cool. That's exciting. That's fun. Hey, thank you so much to Dr. Last and your team for inviting me to participate. I know that you went to a lot of other people before you got down your list. Like, well, I guess we'll invite that guy. He, at least I don't know, at least he's at VCU, so maybe he can like be in the same office as Bryce. Really do appreciate it. Thank you for inviting me. I'm going to talk a little bit about some work we've been doing in the Commonwealth of Virginia, monitoring fidelity statewide for a number of evidence-based programs that the state is implementing. We have a big team that does this work at the Center for Evidence-Based Partnerships, and I'm highlighted in pink there, but I'm just one of many people. And at least one of my team members is here today. I saw Ashley Robinson pop in. And a lot of the things we're going to look at today are things that she's directly responsible for, and all the good things are done based on her excellent work. So I'm really glad she's here to see. Here's our vision. I won't read it to you, but we really focus on access to services, and we believe strongly that relationships are a key to getting those things to happen. Relationships at a state policy level, also at a local implementation level. And so that's why partnerships is in our name, and we focus on evidence and equity, accessibility, and evidence-informed services. We do a number of things for the state of Virginia. These are sort of the 4 buckets that we think about our work in, and the one we'll talk about today is this one around fidelity monitoring. We monitor fidelity for all of the programs that are in the state's Family First Prevention Plan. And the Family First Prevention Plan is something that states who've chosen to participate in the Family First program have to have a plan. They list their EBPs in there. And then for each EBP, they have to monitor fidelity and be prepared to present that data to the feds. Whether the feds ever ask for it or not is another question. For the federal law to be followed, the state has to report fidelity for all of the kids who received services through the funding that's part of Family First. And most states are struggling to fund any kids under Family First because Medicaid tends to fund almost all kids that would be eligible for Family First. So what we've decided to do in Virginia is we just are doing fidelity monitoring for every kid who's receiving these services, so that, and then we can compare the kids who are getting the Family First service to kids who are funded on Family First to kids who aren't. So the first question one of the questions I was asked by Dr. Last and her team to address is, does fidelity matter? And we focus on this a lot. It's since I was a graduate student back in the holy cow 90s, right? The 1990s. It's kind of crazy. Some of you weren't even born then. And there I was in graduate school slogging through. We were told fidelity is like super important and you've got to do it. And Mantra and Prinz and all kinds of people were writing about it at the time. This is really, really important. Then we do a bunch of studies and we're like, I'm not so sure about that. We're not really seeing it, but it is one of those things that in science, sometimes it's really hard to kill an idea that makes logical, conceptual sense, and then you can't find the data to support it. You don't abandon it, but instead you stick with it. So I think it's important that we recognize that many times we look for this link and we don't find it. We do find it sometimes, and what is it? A stop clock is right twice a day, or, exceptions happen. I don't know what the truth is, but we still focus on fidelity in Virginia. Well, why do we do it? Probably the number one reason is the feds require that we do it, so we have to. But also we have found it's really important for our policymakers to understand, are we getting the service that we are paying for? So they are paying for these services, they're paying for training in these services, and are they actually getting that? So quality assurance. Talk a little bit about quality improvement too. Some of the things we do are quality improvement related in order giving feedback directly to the people who are delivering the service. But we don't do a lot of that work. We focus more on informing policymakers and localities about here's the services you're getting. So here's what we do. Here's our team. And Ashley, Catherine, and I really work hard to pull these reports together. What I'm going to show you is data from one of the EBPs that we monitor, just as an example, and I'll walk you through some of the way we think about it. And this will get to some of what Bryce was saying about definitions. And we say fidelity monitoring because that's what the federal law says. So the federal law talks about fidelity monitoring, so we use that phrase. And then what we have done is developed for each EBP, and there are 8 EBPs that are in the Family First Plan in Virginia. We've developed a model for each of them, and they're multi-component models, and they include things that people might not necessarily always think of as fidelity, and we could argue whether they truly fidelity or not, but they are quality indicators. One of them that's really important and was one that we actually spend a lot of our time focusing on is sort of the health of the team or the practitioner. That is, are they trained? Have they been maintaining their training? Are there enough people on the team? And then also, that's good. Oh, good. I didn't realize that I had that. So their training status, the team size, and then most importantly, their caseload, because a lot of these EBP purveyors, the people who do the training, will say, you have to have a caseload of this to this, and you don't want to go too far over that, but you also don't want to go too far under that, because that helps to maintain the quality of the service. And so these are all data points that we get our hands on and look at. We're also keenly interested in funding source. It's really not a fidelity indicator, but for the state, it's critically important to understand who's funding these services and how are the outcomes and are they different across these funding sources. And then we look at what we might be considered traditional fidelity indicators like adherence, competence, et cetera. And then we also look at outcomes, and this is what the state is truly interested in, are primarily outcome related things. And so we look at things like, is the child remaining in the community? If you think about the Family First Law, this is really designed to revolutionize the child welfare system, which is focused historically on, I'm going to air quotes, protecting children really, but it's really focused on policing families and pulling children out of families at any sign of anything going untoward. And as you probably know, in child welfare, child abuse, and neglect, most of the reports coming in are neglect related, and many of them are poverty related. So pulling kids out of homes for that. And it's also extremely expensive for the state to do any of these residential kinds of placements. And so they're very interested in remaining in community, remaining connected to work or school, and then any kind of recidivism, because a number of the children that we're going to talk about in these models are in the juvenile justice system in Virginia. Okay, so this is how we do our fidelity reporting. I am going to breeze through this and be done so early. I can just tell already because these graphs are just pretty and nice. So these are things that Ashley Robinson and I, when we first started building these reports, built data sharing agreements with all the purveyors, and then also with every provider company in Virginia that's doing these services. So we have data from the providers, and then we have data from the people who are doing the fidelity monitoring. And then we pull all that together, and then we build a report every quarter for the state that we then present to the state in a written format, but we also do a 1-hour presentation where they can ask questions. And one of the big challenges that we had was that we had hundreds of data points that we could share, and we really did not want to bombard people with data. And so we focused on like, how can we tell a story with these data that the state wants to be interested in, and also that we think the state needs to know. So what I'm going to do is show you just a portion of the things. We probably have about 11 or 12 data points that we share in the report out of, I don't know, 35 or 40 data reports for each of these that we could share. And then we sort of gauge the reaction from people to see whether we need to change things. So one of the first things we focus on are that sort of team health. And so in Virginia, there are 11 functional family therapy or FFT teams in Virginia. And you can see at the bottom of this graph, there's the number of cases that they see, and then the number of therapists that are seeing those cases. And then you can see this is really all of last year, 2024. These reports come out quarterly. We start collecting the data at the beginning of the last quarter, so that we're just now getting Q1 data, and that Q1 report comes out sometime in the middle of Q2. So like in the quarter we're in now, but like later in May sometime, we'll get that report out. So what you're looking at here are the total number of teams. And so it looks like there's an increase in teams, but there really isn't. And this is just a data anomaly that we explained, that up until the midpoint of 2024, one of the 11 teams didn't want to share their data, and then they changed their mind. And we were like, welcome to Virginia. And they were like, awesome. The red line is the important line to focus on, and that is the average cases per team. And you can see that this number was increasing for a while and has gone down. And this is a continuing concern. And so this is something we bring up a lot with the state, is that there's not enough referrals, and those referrals have to come from multiple sources. And I can answer more questions about that before, but a lot of our focus in the center is on educating, disseminating information about this service to the locality so that they will make referrals. This is another really big important. These are the number of therapists per team. FFT wants to have at least 3 people on every team. And you can see that Virginia, on average, the gray line is like right hugging that line. So there's not a lot of room for this to go south. And you can see that the worst team in Virginia has always been below. It's not always the same team that's down there below the number, but there is always at least one team in Virginia that doesn't have the desired number of therapists. And that, as you know, is because there's a huge workforce crisis that's going on, and licensed people in particular are extremely hard to find in Virginia. And Virginia right now has a regulation that says that there needs to be more licensed people on the team than unlicensed, what we call in Virginia qualified mental health professionals. This is something we've actually advocated for them to change, and there's a draft policy that's probably going to happen in the next 9 months to make this a bit better. And then we expect this to get better, but this is a significant problem for Virginia. This is also goes along with the first thing we mentioned. So this is one of our most favorite. Ashley Robinson did such a nice job with this graph. So each of those gray lines represents one of the 11 teams. And then the red line shows you the average number of cases per therapist. And the goal is to be at 5. And you can see that we are not at the goal. although some teams are sometimes at the goal, but in general, most teams are below the goal. And this is really a referral problem. And also in some cases, it's a problem of the team dropping below the number of therapists they need and then needing to focus on retraining therapists versus taking cases. And so this is also a big problem for Virginia. What's not a problem for Virginia is fidelity. So Virginia and FFT has never had trouble maintaining fidelity, even despite all of these various challenges with cases and number of therapists per team. The FFT teams, our fidelity scores are quite robust. And also the outcomes are good, although not as good perhaps as we would like them, sometimes falling below the threshold there of 85% of kids remaining in the community, but in general staying very close to that. And what you'll see in this graph is that this only captures closed cases. And Ashley will correct me if I'm wrong, but I believe this is also a more conservative estimate of this because we also include cases here that there's another group of cases that are included. So we sort of are doing an intent to treat sample with this group. And so this is probably, if we only included kids who actually went through the treatment all the way, they would look a little better. But still, this is very prompt, very good news. And now for the money graph, which is where the state policymakers, this is what really gets them excited. And we spend most of our 1 hour meeting talking about this graph. This is how these services are funded. And as you can see, Medicaid obviously is the dominant payer. And this is particularly important for Virginia as a state that did Medicaid expansion, but has a trigger law that if Medicaid is reduced at the federal level, then the Medicaid expansion is taken away. And then it goes back to the Medicaid the way that it was, say, in 2016 or so, which would have a devastating effect on these services because you can see that most of them are funded by Medicaid. The thing that I want to point out in the couple of minutes I have left, I'm good. So I'm good on time. Is that the yellow part of that graph is Title IV money, and that's what the state really wants to see get bigger. And you can see it is not working, and FFT is going to be a tough road because of Medicaid funding it, and there's a specific Medicaid rate for FFT, so it's a desirable service for providers to provide and also to get to go for Medicaid for. There are other EBPs in the plan that don't have a Medicaid rate, and so there's more focus to get Title IV funding for those. Speaking of services that don't have a Title IV or probably a Medicaid rate, is this motivational interviewing. And I thought I would tack this on. It's a little bit of a quality assurance and quality improvement project that we've been working on with folks at the Virginia Department of Social Services. We had recommended very early in our time in Virginia that the state train everybody in the child welfare system in motivational interviewing. This was something that the District of Columbia was doing. And it's really a way to change the culture of child welfare from like we're policing families to we're actually partnering with families to help them keep their kids in their homes. And so the state agreed to do this for their in-home staff, not every staff they have, but for the in-home staff that they have. So they've begun training. They've done 7 cohorts. Cohorts are trained. And then the 8th cohort is planned for this summer. There's about, 600 or 700 people total trained. And there's a 2-pronged fidelity monitoring approach that we've developed with them. The first is self-reported fidelity that they do every 6 months. And then about 25% are doing a simulated client fidelity check with us, where we have 2 team members who are trained as simulated clients, and they will interact with these workers for about a 15 to 20 minute sample. And then those will all be coded using something called the MIGHTY, the motivational interviewing treatment integrity tool, I think. We've already done self-report fidelity monitoring. I thought I'd show you some of those data so you can see how those are going. The first 3 cohorts have done that already. These are the self-report completion, and you can see that the completion is going down. One thing we've done to work with VDSS, so VDSS doesn't want us to communicate with the workers directly. They want to do all the communication. They're their employees. And so we've encouraged them, and they've started to do reminders. So they hadn't been doing reminders, and we were like, reminders are a really good idea. If you remind someone, they'll remember to do it. And so we're actually seeing for cohort 4, and then cohort 1 is doing their second one. We're seeing better rates in the early going on both of those. These are some of the measures. I don't know how many of you are familiar with motivational interviewing. There's sort of spirit, and then there's process. motivation, spirit, the spirit of MI, and then the process of MI. And these are the overall scores for the 3 cohorts. And you can see that the scores are relatively similar across the cohorts. And the other thing to point out is we ask them to report on their case difficulty. So they're asked to think about one specific family or case. They're actually told, they're given 2 different ones, and then they can select among those 2 from VDSS. This is the last, I think this is my, yeah, I'm almost done. So that's good. We're doing good. We also are using this for quality improvement. So this is the quality improvement part of this. Most of this stuff is to help the state see what's happening. But here we're showing specific areas of strength and lower scores. And then we feed this back to the training organization that's doing the training. And eventually VDSS is taking over the training of this. So they'll use this to say, we need to focus on reflections. This seems to be an area that is identified by the workers as they're struggling doing. They're handling empathy and engaging really well, but they're not really doing the reflection piece very well, and which has been good too for us to see that they're actually reporting. These are 1 to 3 scores, and so you can see that they're obviously not just putting a bunch of 3s down, which was a little bit of our worry about this. So in closing, it's a little sad we don't know fidelity and outcomes. We actually are going to be able to test some of that in Virginia. We'll be able to say whether fidelity is related to outcome, especially for FFT and MST in particular. We'll be able to do that. And then there's a small thing we're doing around brief strategic family therapy, BSFT, where we'll have some good outcome data that they're doing with some of the MCOs here. But fidelity as a part of a quality assurance or quality improvement program, we really think is a great idea. And that's what we're spending our time doing. And this is my last little point. This is my plug for, we're finding, and we've advocated in Virginia for fidelity to be essential as part of a program where we involve folks who aren't licensed master's degree holding in the workforce. And I mention that because we have a freaking disaster in the workforce area. There's just literally nobody available to provide services to families, and especially not licensed people. I was doing a talk just yesterday in Roanoke, Virginia, and there was a child and adolescent psychiatrist in the room. And I was like, oh my gosh, you're like, it's amazing. And he said, yeah, he's never not busy. And we are overwhelming our behavioral health workers, and we need to think of ways to extend them. And one way to do that in Virginia, at least that we're experimenting with, is using qualified mental health professionals. These are folks who have a bachelor's degree or higher, but are unlicensed, and they can provide some parts of this service, including they can be on FFT, MST teams, BSFT, etc. I will stop there, and I cannot wait to hear what Shannon has to say.
All right, thank you. That was great to see the work that you're doing there and how that's coming. And this is not I'm going to focus mainly on adaptations, and you'll see a little bit of fidelity and adaptation data as it relates to outcomes. But I will tell you that some reassuring news from some work that we did recently is that self-reported fidelity, just people doing checklists of what they did in cognitive behavior therapy sessions and cognitive processing therapy sessions. First of all, we did see an association with observer self-reports or with observer reports of the same things. But we also saw that the self-reports, actually even more than the observer reports, were associated with subsequent symptom change. So that was good news. And we saw that both in CBT and cognitive processing therapy. And this was for adults in the populations we were working with. But and then I was working with a postdoc, Nikki Gumport, who's found some similar things for CBT for sleep. So we are starting to see that these self-reports might actually be meaningful. And in some ways, it's great news, right? Because if people can use that self-report as part of their documentation and it's actually predicting better outcomes, maybe we don't have to sit and watch tapes. So some good news there, at least reassuring. And also, there is the value of keeping people on track, right? When they're watching, when they're kind of watching themselves and knowing that they've got that kind of accountability piece. I do think it helps people just remember what parts of the protocol are that they might otherwise kind of let fall by the wayside. We all get into habits where certain things get emphasized and de-emphasized. But today I'm going to focus a little bit more on the adaptation piece. So I've got my slides up now. I think everyone can see them. Okay, perfect. And I just want to mention that this is the work of many people that I'm presenting here, and I appreciate the collaboration and the opportunities to work with a lot of really great folks. So just to sort of situate the thinking about adaptation and modification and fidelity, the way that I tend to think about in terms of definitions is modifications are any changes that are made, whether planned, unplanned, just modifications equal changes. And then within that, adaptations I think of as a little bit more planned and either data-driven or, driven based on theory. If, if there's some sort of theoretical reason or practical reason that we would need to make a change, we would call that an adaptation. And then within this broad category of changes, they can be consistent or inconsistent with the protocol. So, you can make changes where you're just tailoring some language, you're presenting concepts a little bit differently. Maybe you're simplifying, one of the therapy worksheets or something, but you're still doing it. And then there's kind of a change where, you're dropping a part of the protocol, or you're doing something, you're integrating something that's theoretically inconsistent. Those would be fidelity inconsistent. And so you can see that sometimes, but not always, at least historically, there was thought to be a big tension between fidelity and adaptation. And I think that's not always the case. We can have these kind of fidelity consistent or protocol consistent modifications that can actually go towards, I was glad to see Bryce bring up the dynamic sustainability framework, the idea that we can actually be optimizing these interventions as we go by not dropping the theory of change, by making sure that any changes that we make to the protocol are consistent with the theory of change, but that we can make some changes to make it more approachable, to make it fit better within a particular context, to help address constraints within the setting, or make it something more aligned and sort of congruent with some of the maybe cultural norms in an environment where we're working, that can actually help make the treatment more accessible, more approachable, and perhaps even more effective. And so with that in mind, when we think about whether, when, and how to adapt or make modifications to a treatment, what we all like to think of, when we're sitting in our offices is this kind of upper right quadrant, this theoretically optimal, like we have some advance notice, we know something's going to be different, we know that, maybe there are differences in language, or, this is a setting where we're only going to be able to have 4 sessions instead of 6. And so we're going to be able to be, really thoughtful about how we do this. And, so we'll make planned, fidelity consistent adaptations. And then life happens and we're almost never in the upper right quadrant. I mean, we get curveballs either, in our sessions, or, life throws us curveballs, like the pandemic was a big curveball, and all of a sudden everybody had to make very quick changes, unplanned, reactive changes, at least initially, right? Where everybody was doing the best they can. And, they moved to FaceTime sessions, or, in some settings, people were starting to do home visits and, roll down the window of the car and talk to somebody from 10 feet away standing in their yard, or whatever they could figure out, right? And then over time, actually, there was more of an opportunity to say, okay, well, now we're going to, we've had some time, so now we're going to come up with, telehealth that's going to, be HIPAA compliant. We're going to be really thoughtful about whether, things that we initially dropped from the protocol are things that we could actually integrate back in, but just in a way that takes into account these differences, like the fact that we're now on telehealth, or we've got to do the sessions by phone or something like that. So, ideally, in unexpected circumstances, we'd be over on the right, with unplanned, fidelity consistent adaptations. And this is where training is really important, right? We can tell people, like, hey, if you're going to make changes, when something comes up, here are the things you want to preserve. Here are the things you want to be really careful about not letting go. But can you be creative in how you make those things happen? Perhaps, right? And when we can't, ideally we're collecting some data whenever possible, so that we can make sure that changes that we're making are actually leading to the outcomes that we're hoping for. But if we do have to make fidelity and consistent adaptations, we have some opportunities for learning. It's entirely possible that in some contexts you can drop something and it's not going to make a big difference. And then we've learned something important about how to, streamline the treatment, or something that could be optional, or something that actually, isn't necessary, at least with some segment of the population. So, being able to measure, especially when we move further from the protocol, can be really important, because we can learn a lot as we go, including whether we need to sort of go back and talk with, the clinic, the program managers, the leadership, and say, you know what, we had to drop this because of, we only have 4 sessions, or because we're not allowed to do these exposures that are, that require us to leave the building or something, and we're just not seeing such good outcomes when we do that. So can we figure out how to bring this component of the treatment back in so we can get the outcomes that we're all hoping for? So I think it's really important to talk about, when we talk about fidelity consistent, it's really, we think about consistency with the core elements or the core functions of the protocol. And so these are really the parts of the intervention that align with the theory of change. These are either empirically or theoretically associated with the desired outcomes. So if you believe that your intervention works because you're able to do cognitive restructuring, and really sort of help people change the way that they've been looking at a situation, change their perspective, you can be pretty creative about how you do that, as long as you're still working with them to, address the way that they're thinking about the situation, and help them, come up with a belief that's more balanced or more fair, or, that is sort of consistent with the full context of the situation, right? But if you drop that piece, if you say, well, we're not going to do any cognitive restructuring because people don't seem to like it, or, we can't do worksheets here or something like that, then you're dropping something that's probably a core element of that treatment. So some recent thinking in implementation science has been to think about core functions rather than the forms. So maybe you're not doing a CBT worksheet with someone, maybe you're doing catch it, check it, change it, where they don't actually have to write anything down. So you're still addressing that function. You're still catching the thought, checking it and trying to make a change if you're doing a cognitive intervention, but you're not doing it through writing. So you're still addressing the core function. Another kind of easy one is psychoeducation. Maybe originally, you had a treatment provider, devoting half the session to talking through the theory behind the treatment and why you're going to do it, and, psychoeducation about anxiety, for example. But now you're working with, non-licensed professionals, and you realize that it might be a little easier to standardize this if we watch a video together, and then we have the, the practitioner have a discussion about, like, what do you think about what you just saw here? Does that make sense for you? Can I clarify anything? How does this play out in your life? You're still attending to the function of psychoeducation, but the form is different. Now we're going to watch a video together. And, the core elements, what's really core and essential might not be the same in all contexts for all people. That's where, if we take this data-driven approach and we think about the dynamic sustainability framework, we might be learning that some things that we thought were core actually aren't. And so I think it's important to really think about, maybe if you're working with some families who are, have really high levels of health literacy, you don't need such intensive psychoeducation. You just need a little bit. Whereas for other people, it might be the first time they're hearing these things, and it's really essential. So thinking about what's essential for different, for different segments of the population you're working with might be important, and we have a lot of opportunities to learn there. So now I'm going to talk briefly about how we document these adaptations, because I think when we started really thinking about modification and adaptation, there was a sort of like, is it good or bad question? And the people who are sort of out there in the field trying to implement were saying, they're good, you got to do it. And the people who developed these treatments, I'm grossly oversimplifying, were like, no, they're bad. Like, we have to think about treatment integrity. And the reality is probably that it depends. And so part of what it would depend on is, what kind of adaptation you're making. So the goals of documenting are really to, figure out like what are we, what changes are we making? And we can share that with other people who are implementing. We can share that during training. Look, people have been able to do this and this and this and think the outcomes seem to be good. So consider that on the safe list. We also want to be able to look at process data. So let's say you have an adaptation or a modification that's, maybe less than theoretically optimal. If you're documenting that, you can say, our outcomes didn't look as good as they looked in the clinical trials, but we made these changes, and that might be part of why. We can link adaptations to outcomes, and I'll show you some data where we tried to do that in a study. So what kinds of outcomes can we expect if we drop these elements, or if we make adaptations that are fidelity consistent? And then, as I mentioned a minute ago, we can actually think about refining the protocol based on what we're learning. Or we can, share in training, like, we've actually been able to see that, you don't have to get people to write this down on the worksheets. You can have them do it in apps. You can have them just remember, some key ways to sort of look at the perspective they're taking on a situation. You can, you can develop a hierarchy by playing a game with somebody, like, would you rather? There are different ways that you can adapt what's in the protocol that are consistent and might actually be more engaging. So lots of good reasons to do this. And so, of course, we had to come up with what looks like a very, and I apologize, complicated framework. But this is basically for the entire process. And what I tell people is, depending on what your goals are when you're working, you might use some of this, or you might use all of it. So if you're writing a grant and your whole grant is really about studying adaptation, you might really want to check in on all of these different elements. Like, when did it happen? Did it happen during implementation because we got thrown a curveball? Did it happen when we were trying to scale up and we didn't have the resources? Did it happen, really proactively during pre-implementation? Were these adaptations planned or unplanned? And sometimes what I'll do is we'll just take a sheet like this and put like a little check, kind of a checkbox by each of these. And, so you can do one per adaptation that's made. So who decided? Was this something that the administrators decided, that the providers decided, that community members decided? And then what are we modifying? Is it really a change to the content, to the context, like how it's delivered? The modifications to training and evaluation and implementation activities, we now cover what we call the frame IS. So this is the frame for implementation strategies, because people started trying to apply this framework to, adaptations of implementation strategies, and it didn't quite fit. So we made a different one, which I'm not going to go into today. But, there are different ways that in the course of an implementation project, you might be adapting the treatment or the context. So it can also be important to learn, are people making adaptations for individuals, or are they making them, so for just specific people that need a change? Maybe this person, isn't really comfortable reading and writing. So we figured out a different way, we've figured out a different way to kind of introduce the concepts and practice them. Or maybe you're doing it across the whole network or system. So kind of looking at the level can be important. You can also look at, who delivered it, or the, changes to the format, changes to the setting. Are we making this web-based now? Are we doing it outside of the clinics and school settings? Are non-licensed professionals doing this? Or are we changing who we're delivering it to? So that's this box. I don't know if you're seeing my cursor, but let me see if I can use one of these little like highlighter.
Yeah, we can see it moving around there.
Okay, great. So then the over here, the nature of the adaptation is really like looking under the hood. So you're watching the session and you're seeing, are we substituting something? Are we reordering how we do it? Are we spreading what's supposed to be a 3-session intervention over 6? Are we integrating other treatments, et cetera? So a lot of times in studies, people will just do this. That's all they'll do. They'll do it at a session level, or they'll ask people once a month, or they'll ask people, just once in an interview, some of these questions. But we also have questions about whether or not it's consistent with Fidelity. And then we also want to know the why. So all of this is the kind of the what, the how, and then down here we have the why. So what was the goal? Were we doing this because we wanted to increase retention or engagement? Did we want to increase our reach? Do we want to address cultural factors or sort of reduce health disparities in some way? Do we need to reduce costs? Do we want to make it more feasible? Do we want to try to improve the outcomes? And then also the reasons map onto some implementation determinants and also some social determinants of change. So, is this happening because there are constraints within the setting, because there are policy, or some mandates that kind of dictate how we need to do this aspect of the treatment? Are there provider level reasons or reasons having to do with the recipient? So this is sort of the big, just the big picture, if you want to kind of document the whole process, or if you just want to use parts. And we've also had people tell us that, sometimes there's a whole coalition or a whole group that kind of sit down to really think about making changes. Other times there's one decision maker, and that might end up being really important. Who ends up deciding, and is that predictive of outcomes or how, how much the treatment is adopted. So we can do this a few different ways. We can interview people, and these are some of the questions we would ask. We recommend that someone's pretty familiar with the code book, so that they can ask the types of questions to help them differentiate between, two different types of content adaptations, for example. Also to kind of look at level, we ask, did this happen across the board or just for some people? Why did you do it? And then I always like to just ask, does it seem to be working, and how do you know? Because sometimes people make a change, they don't really reflect. Or sometimes we see this kind of vicious spiral, this kind of vicious cycle where, people say, well, I didn't really think that it was going to work to, assign practice between sessions. So I kind of dropped it, but this treatment didn't really seem to be working very well. So I kind of integrated something else from another treatment because it wasn't really working. And, and so you end up seeing this cycle. So just asking people to reflect on whether and how it seems to be working, I think, can be really informative. We can also observe. So this would be something you would do in conjunction with a fidelity measure, ideally, so that you can make determinations about fidelity consistent and inconsistent. This is just a sample from cognitive processing therapy for trauma. So we ask questions around, do they seem to be primarily working from a CPT approach? So these big picture type questions. Did they drift away? Did they drift away and come back? And then we start asking questions about some of the elements that are on that content list, like, they shortened it, they lengthened it, they loosened the structure, et cetera. And then for self-reports, we have a couple of different formats that we've looked at. We've done, at the session level, did you make any of these changes? And then we've also asked, things like in the past month or, whatever time period. And then we've asked them, I didn't do this for anybody. I did it for some, but fewer than half. I did it for most. I did it for all. And so that gives you a sense of how widespread the adaptations are. And just to show you, this was some data from Danielle Schultz's dissertation, which we have not published at this point, but she was looking at what kinds of adaptations were made. These were providers doing cognitive processing therapy in the VA and in community settings in the US and in Canada. And we found that higher caseloads were associated with more fidelity inconsistent modifications, which might make sense when you just got a lot going on. Maybe you're not sitting there and really reflecting on, is this consistent with the protocol? And they also made them with more of their patients. And then you can see that some of the adaptations that were made tended to be things like around integrating. People did that because they wanted to integrate skills from other interventions, tailoring, which is really kind of a fidelity consistent modification, just sort of maybe changing wording. And they said just, these are different nuances. Repeating, sometimes they say, we've got people that we have to just review concepts more. We have to go back and reteach things. And actually there's some data that Stephanie Yu and colleagues found that might not actually be, that this repeating might actually be associated with lower coverage. So even though people are repeating adaptations, in another sample that they did, I think in LA County, they found that sometimes means that there's a trade-off and not as much of the intervention is covered. And then lengthening the protocol. So, I don't do it in a single session. I don't like cutting people off. So I'm going to let them talk more, even if it means that we have to spread something out over more sessions and then, lengthen the protocol. So just to show you some of the things we've done after we collect these data, this is from another study that was done just looking in the medical records in the VA. So a very brave team of people that did not include me actually looked at all of the charts for, it was 7,297 EBP sessions. These were either prolonged exposure or cognitive processing therapy for over 1,200 patients seen by almost 200 therapists. And what was really interesting here is we looked at the proportion of variance that we could attribute to the therapist and to the patient. If you want, if there are adaptations that we're making because there's some sort of a need, a patient or client level need, then, that might be something that we feel a little better about, right? That, we're tailoring in response to the patients, right? We are, this one's in the weeds about switching CPT types, but integrating another treatment because this person seems to need a little MI, something like that. What we might worry about or what we might think is a training issue is if we see therapists always, integrating other treatments, no matter who's in front of them. Lengthening the sessions, extending this seems to be almost equally driven, but maybe a little bit more by the therapist. So does this mean that we could help therapists figure out how to be a little bit more efficient in a session, perhaps? Shortening sessions, that seems to be patient-driven. This might just be they're late, and so we had to do a shorter session. Repeating actually seems to be a therapist driven adaptation. So, it might be that therapists really believe, well, unless people really get it and they get the whole concept really well, I can't move on. And actually in this particular intervention, it's something where there's a lot of scaffolding and one thing builds on the next. And so, but they also get to go back and keep practicing the skills, throughout the whole protocol. So maybe they don't need to repeat. This might be something that we could address through training with a therapist. So we learned a lot, by trying to figure out, also removing seemed to be therapist driven. This seemed to be like I find that this isn't helpful for people, so I don't do it. And so, this really gives us some good information about where we might need to address some different adaptations and changes in training and consultation, and where we might be learning about things that we could actually do to try to help support our patients better and things that might be necessary. And we can provide some guidance around that. So now a big question for us has been, if we want to look at these questions of is adaptation good or bad? And the answer, of course, is probably it depends, but we can't really look at that until we start to look at, well, what kinds of adaptations are we talking about? And what kind of outcomes do we want to look at? And I think, I'm sorry, I'm trying to not use this word anymore. I did not change it on the slide, but what outcomes matter to our partners? Are they really wanting to make adaptations, or are they really caring, just as much about whether or not people are engaging in the intervention as they are in the outcomes and the level of clinical change? Is it about feasibility? Is it about satisfaction, either at the therapist level or the consumer level? So it's always important to ask these questions about what matters, when we're looking at outcomes. And I want to show you a study where we worked with a community mental health agency that was implementing cognitive processing therapy for post-traumatic stress disorder. There were 19 therapists in this study. They worked with 58 clients. And these were individuals, there was a lot of immigration-related trauma. There were about half the sessions were conducted in Spanish. So this was in a rather pretty poor county outside of Boston. I think it was the poorest county in the state. And so there were a lot of social needs in this population. So first they piloted the protocol, then they made adaptations. And one thing that we learned is the outcomes actually didn't differ between the adapted and original version. So we didn't optimize outcomes, but we did have a protocol that was more acceptable and where we didn't see, sort of a downgrading in terms of our outcomes. But all of the CPT sessions, every session was coded by observers, and they looked at both fidelity and adaptation. One thing that I found reassuring, and we also found this in our checklist study that I was telling you about, is the mean number of sessions attended were about 8. There were, I think, 9 in our checklist studies. And this is consistent with what's considered to be an adequate dose of the therapy, and pretty consistent with what we see in the VA settings too. So this seems to be, in public mental health settings, working with adults who experience PTSD. 8 is considered an adequate dose. We often see a lot of change over 8 sessions. And in this population, we saw that 68% experienced clinically meaningful change at or before 12 sessions. So we looked at, and I didn't include the figure, but we looked at models where we included adherence, competence, and then we looked at fidelity consistent adaptations. At least in this study, fidelity inconsistent adaptations were essentially the inverse of adherence. So it was basically people dropping things. If there were fidelity inconsistent adaptations in this sample, then it was basically non-adherence. So we didn't include that because we already had the adherence in the model. But I will say there are other times when there are fidelity inconsistent adaptations that are not just the opposite of adherence, like integrating a theoretically inconsistent model, or something like that. But in this case, we had 3 things that we had. We had language, and then we had adherence, competence, and fidelity consistent modifications in the model. And on average, there were about 1.5 fidelity consistent modifications per session. Often it was something like tailoring. And what we found was that, you know what that is? I deleted something I wasn't supposed to delete, so I'm just going to have to give you the punchline here. Nope, there we go. Sorry. So higher adherence was associated with greater decreases in depression. And that might be because in this particular protocol, there are some kind of behavior components that help people kind of get back out and engage with the community more. And making sure that, those pieces were done. And also just that a lot of it is cognitive restructuring. So those are higher adherence was associated with greater decreases in depression. Higher competence was associated with greater decreases in PTSD. And then over and above adherence and competence, fidelity consistent adaptations were associated with greater decreases in both PTSD and depression. So it's some nice evidence for something like the dynamic sustainability framework, which suggests that you can optimize treatments when you're adapting them and doing them, in a particular setting, right? So we were able to make some adaptations and see that we actually saw better symptom change when some of those fidelity consistent adaptations were made in the sessions. I also want to show you some work that Stephanie Yu and colleagues did. This was a study, a mixed method study, where they looked at 680 sessions with 273 clients. And this, I believe, this is in LA County. So they were looking at therapist-described adaptations, and they coded them into 5 different types: modifying the presentation, integrating, extending, reducing, and generalize. And then they also coded generalizing, and then they looked at the reasons for adapting. And then they also used the EBP Concordant Care Assessment Observational Coding System. And what they found, these were more looking at implementation outcomes, that modifying presentation adaptations were associated with more extensive therapist delivery of EBP technique strategies. So the more that they modified the presentation, they saw that meant that they were able to do more extensive delivery of EBP techniques. And then the more they extended adaptations, so a lot of this was repetition, this kind of repeating session content was associated with less extensive delivery and perhaps lower dose of the EBP content and technique strategies. So by kind of repeating, there was a trade-off. Something else wasn't happening. So I think that's an important thing to be able to look at, because then we can kind of understand, how adaptations play out, what the implications are for things like fidelity. And so one of the things that we can do when we're doing analyses like this, and when we're taking a look at the types of adaptations that are made, especially in conjunction with fidelity, we can start answering the question that Chambers and Norton posed around, what adaptations work in what contexts for whom. So the more data we collect on this, the more we can start to understand. And there have been some meta-analyses that have been done showing that You're probably better off, if you want to add things to a protocol, you're probably on more solid footing than if you're removing things. And that, making things like cultural adaptations can be associated with, either greater symptom change, or at least that you're not making compromises in terms of outcomes when you do that. And so the more we document these adaptations, and I would say, based on some of the Marcus et al. Study, the more we document them in conjunction with Fidelity, the better sense we'll have of the answers to these questions. So I'm going to wrap up here, and we'll have time for questions. But I did want to share that we have some resources on our website, which is right here, but I always get to it by just Googling FastLab adaptation, and this page will pop up. And we have things like a frame coding sheet, some different sample checklists. We have a nice sort of spreadsheet that Alex Stopp and colleagues put together to document adaptations. We've also got different checklists and things you can use. So, and we do have some papers, but we don't have all the frame papers. We have we don't have all the papers that use the frame or anything on there, but we do have some resources that hopefully are helpful. And so with that, I will wrap up, and feel free to reach out to me if you have any questions. And I think now we're going to be able to take questions.
Thanks so much, Shannon. And thanks to our wonderful panelists. Those were amazing talks, and learned a lot from all of you. So we do have a little bit of time for questions. So just for everyone to know, we are recording this meeting. So if you don't feel comfortable being on this recording, feel free to just sort of put your question in the chat, and I'd be happy to ask it for you. Or you can also use the raise the hand function in Zoom and ask the question yourself, and we'll unmute you. While we're waiting for questions to sort of filter into the chat, I had I was really interested in, Shannon, you're kind of looking at the patient-driven versus the therapist-driven modifications. I thought that was super interesting. And it sort of relates to questions that I wanted to pose to all three of you, which is around, fidelity variation within providers, and sort of like whether or not you observe that, because you're capturing this really tricky dyadic process, and we're trying to focus on, the provider level, because that's what we can, control, and that's what we're interested in, is sort of quality assurance. But, even I, as a therapist, I know that I'm a better therapist when the client themselves is motivated and engaged in treatment. And I feel like I'm much more sort of, faithful to a protocol, and it's much more challenging when someone's not responding. And, you can imagine a scenario in which the reason you see a relationship between integrity and outcome is because it's just much more difficult to be faithful to a treatment when someone's not responding. And so I guess I was just sort of curious about whether you see variation within providers, and sort of how you think about that from a training perspective and supervision perspective.
And I would say definitely see quite a bit of variation within providers. And I think of it a little bit of, you've got, and I love the model that Shannon put up there, you've got kind of provider level variance, you've got client level variance, and then you have the interaction between the two. And you can, in youth mental health, you can kind of think of someone who's really comfortable working with kids, but maybe really uncomfortable working with adolescents. And so that's the interaction, right? So you're kind of thinking about, what does a provider bring to work that might interfere or interact with their fidelity? And some of it's their own comfort, some of it's training, so providers bring a lot of things to the table. In effectiveness and implementation researcher, you rarely have a blank slate like beginning clinicians. They usually bring their own opinions and everything, and those things may help them feel more comfortable. They may interfere with their learning. They may have attitudes and a mixed feeling about it, but and I'll let the other folks talk, but I would definitely say that when we look at fidelity across a variety of settings, prior to training, there's a fair amount of variability in the practices. Post-training, there remains variability in the practices. And I would say that kind of this issue of like fidelity outcome, I don't think that we have to hit 100% fidelity on the top of our scores to promote good outcomes. And that's always the question of like when you're training someone, if you're using, for example, maybe a 7-point scale, are you trying to get a 4? Are you trying to get a 3? At which point do you start seeing kind of improvements? So if you're thinking about, and our evidence in school suggests it's not a 7, it's more around a 3 or 4. We start seeing improvements. So again, I'll be quiet, but yeah, there's quite a bit of variability, and it has implications for training.
I think we've definitely seen, although we keep wanting to do like an area, like an ROC analysis to look at like what's exactly like the good enough cutoff. But we've also seen that in some of the community-based work, you know, in routine care contexts, like if the therapists are getting about a 3 out of 6 on our competence scale, the outcomes look about the same in terms of like pre-post effect sizes as we saw in the clinical trials. So I think that hopefully that's freeing and reassuring. But I do think it's really hard to disentangle. We've looked for different ways to disentangle kind of the client and the therapist, you know, what they bring to the table. And of course, you have some clients that, you know, make you look great as a therapist because they're running with it, and others that, you know, it is more challenging. And, you know, so I think with observer ratings, halo effects are always something that we have to think about, you know, positive and negative halo effects. And, you know, and I think that it's a really hard measurement issue. And I think practically speaking, you know, when you're working with folks and you know that there are some challenges at the level of you know, what the client's bringing to the table, that is a place we're talking about. When is it a matter of adaptation, and when is it a matter of really thinking about the principles of change and what we need to preserve here? And case conceptualization, I think, is really, really critical in those cases, you know, is being able to pause and give people some support to conceptualize the case and really think about what might be needed.
Mike, I know you've been fielding these questions in the
I've been
chat.
responding to all these chat things. So I don't have any more to add to that on that topic. Yeah.
Yeah, that's great. Thanks so much for fielding these. If anyone in the chat wants to sort of expand on their questions, that would be great too. I'm glad that you brought up case conceptualization, Shannon, because I was thinking about Bryce, you mentioned responsiveness, and that seems like really tricky to get right. The sort of you know, we know like a couple of things, I guess. One is that there are like hundreds of evidence-based treatments, but there are far fewer practice elements that really are going to be, you know, potent for change. And we also know that providers are kind of selectively deploying these practice elements, and some do it in a way that often makes sense for their clients and fits with the case conceptualization. And sometimes it seems like they're drawing on it based on what they like and what they're comfortable with. And so I'm curious, like, this question of responsiveness, like how do you sort of capture that and conceptualize that in relation to fidelity and integrity?
So a lot of definitions of competence take into consideration how skillfully something's delivered and how responsive a clinician is in delivering it. And so there's the technical side of delivering something. You can think of exposure for anxiety. That's a pretty technical intervention, and there's a lot of elements of skillfulness and kind of timing and, you know, clarity of explanation and other dimensions of quality. But then there's the responsiveness, and you know, and in part of that is, does a clinician track how the client is responding and adjust if there are lack of understanding, a lack of involvement, and so forth. And so, not to say that everyone agrees on that definition of competence, but that is one of them that is commonly used. And so, whereas adherence is just dosage, do they do it and how much? Competence has that responsiveness characteristic, because we think of like flexibility within Fidelity, and that's the flexibility part, is being able to read the room, read what's happening, and adjust as needed. And I would say something that, and I saw Mandy on the call here, so I'm going to do a little shout out to her, but like Fidelity's great, but we're not capturing the decision-making component of Fidelity in a lot of our models. Some people are doing it. I'm not saying it's not being done, but Fidelity only says kind of to what extent is it being done in the room? Are we reporting what's being done in the room? A component of this is the decision-making part of it, is how do they case conceptualize? How do they think about putting the elements? And Shannon's work really touches a lot on this, is like what's driving the adaptations? Because it's clinical decision making, right? We can teach someone to deliver something, but there's the clinical decision making behind that. How do you use outcome data? How do you incorporate that into what you deliver, which is part of the training paradigm? And I think that touches a little bit on what you're raising there, is we're not just training them to deliver something, we're hopefully guiding their clinical decision making so that they can incorporate data about what they're delivering, what's being responded, and seeing the bigger picture of what the symptom profile is and so forth. So that case conceptualization, clinical decision-making part, I see as part of the clinical picture and driving some of the adaptations, I think. But, perhaps it's an area that it's considered an evidence-based practice, but we're not particularly good at measuring it within the field of like how well people are doing in case conceptualization and clinical decision making.
Yeah, I would agree with that, because I think, you could just roll tailoring into competence, right? And not even consider it an adaptation. We do it because I think it's an important thing to learn, right? Like, how are people tailoring? Is it that they're talking about something differently? They're, tweaking how they would do an exposure, something like that. I think there's a lot to learn by trying to capture it and understand it. But at the same time, I would say it is a facet of competence, right? That if you're working with something and you're seeing, someone, and you're seeing that they're not understanding something, or you're having trouble reaching them, or something just is not sitting well with them, then a part of being a skilled therapist is adjusting to that in some way. And so I do think that, we could roll some of these things into adherence or into competence. But by doing that, we might lose a little bit of the kind of, that looking under the hood and being able to share in future trainings and, think about how we refine the treatment. And so, so that's why you might break it out and actually kind of treat it somewhat separately.
I'll toss in just a quick thought on that topic, which is, I think, thinking about case conceptualization and sort of clinical decision making becomes really complicated when we think about what the scope that someone is allowed to do at different like licensure or registration levels in a state. So at Virginia, as I mentioned, we use most of our people who deliver services are qualified mental health professionals who within their scope aren't allowed to plan treatment. So they're not allowed to make a plan. They're not allowed to conceptualize. I mean, they're still doing conceptualizing and making clinical decisions in the moment in the room, but they're not the ones writing the plan. So that's where I think Fidelity, it gets really complicated about like how do we structure treatments, and which treatments, which evidence-based programs or treatments in general require someone. This is one of the things we've been struggling a lot with in our center, is which ones require a licensed person who has some credential where they've got advanced training, and which don't. And the purveyors tend to spell that out. So a lot of them will spell that out. And then there's also all that more global research that suggests you could pretty much train anybody to do these things as long as you put the right quality assurance program around them. You've got them supervised, you got them trained, you have some fidelity monitoring you wrap around it. I mean, pretty much anyone, and not anyone, like you couldn't have like my dog do it, but well, maybe we could do some of it maybe, but a lot of people can do things. But you need to have that program around them. And then how do you build that clinical decision-making into it to ensure that you're not adapting in the wrong times, et cetera? It's tough.
Yeah, and I think that's one of the most one of the things that is so interesting is you can train just about anybody to do these treatments and to do them pretty well. And then a lot of times it's the context that ends up being more responsible for sustainability. So, I think that, the training and the way we've been able to operationalize these treatments and teach them to people is a real success in terms of implementation. And then a lot of times it's just working on all the other factors that are sometimes outside of it that practitioners control.
Totally. Well, that's a great way to end it because we're going to be talking about these contexts next Tuesday with Brad Nakamura and Lisa Dixon and Iruma Bello, who are going to be talking about implementing evidence-based practices in public settings. And so hopefully everyone can join that panel as well. But first, just want to give a huge round of applause to our wonderful panelists. That was such an amazing presentation. I learned so much from all of you.